Okay. So in the introductions, I mentioned I'm the clinical chemist here at Ruby. I build tests for a whole number of sections of clinical work. So toxicology falls to me, and we're trying to build in-house toxicology testing and expand our capabilities here. So ethyl glucuronide, ethyl sulfate came onto our radar in a big way about 1.5 years ago, and we launched our own testing in the last year, but I've been watching this since the launch because I've been working with Dr. Sperry and Marshalik on this program. So hopefully this will be informative. So I always put this in front of a talk because, I just want to reassure everybody, I don't have any relationships to disclose with any manufacturers. So every opinion I give, everything I say, it's based on what we've experimented in and no influence from the outside world other than that. So the learning objectives, we're going to talk about it. You guys are well versed already in ETG and ETS, so this is not going to take very long. The detection window, I'd like you to really kind of think about that, and I'm glad that this question was broached earlier, so we will talk just a little bit about that. I have a few examples. Some are clean-cut cases and some raise question marks, but they've all been encountered so far. And we've already talked about some, so probably interpreting will be very easy by the end of this. And then identifying the potentially spurious results among them is my goal. And then what the talk is not, in the next slide, is definitely, I'm not going to give you calculus. There's a little math in one section. I promise to make it as painless as possible. But what I'm not going to talk about is HPLC and mass spectrometry in detail, because that'll, unless you need a nap, we just won't go there today. So the who, what, when, as I said, you are all using the test. You're all familiar with it so far, or you're getting that way. And it's kind of a trial by fire thing. We're all learning together. So let's go to the next one. So here's the outline. Ethyl glucuronide and ethyl sulfate are kind of secondary pathways for ethanol metabolism. The classical pathway in the center, ethanol to acetaldehyde to acetic acid. And what we're focusing on is conjugation steps, what we consider secondary ways that the liver can remove compounds from circulation. So ethyl glucuronide and ethyl sulfate fall into that second category and end up giving us some benefits in the process. So the production facts, these are considered lesser metabolites of alcohol. In most cases, you're going to have more acetaldehyde and acetate that's produced, but we can be sensitive enough in our detections now that we can make this a reliable test most of the time. When you pair ethyl glucuronide and ethyl sulfate, that's your best opportunity to know what's going on because of the liver status and the question marks about spurious ETG production or artifactual in other conditions. ETS, though, is a liver product. It means ethanol went through the liver. So that's kind of the harder one to argue against, is ethyl sulfate. So anyway, ETG and ETS, put them together, we can confirm that it's been through the liver, and then we can kind of adjust it to glucose-rich and poor conditions. Right, next slide. So in italics, reportedly, we can detect ethanol consumption dating back days to weeks, and that was the original claim made about ethyl glucuronide and ethyl sulfate. Is we can tell for up to a week or 10 days, and people were making some very strong claims about this. But in our experience here, just from building our own method, that might not be so true, and it might depend a lot on the chronicity of dosing and what kind of patient we're dealing with and what their liver status is, etc. So what we've found is that the technology used and the ability of that technology to reliably detect the compounds is really, really super important. The screen to confirm method is economical, but it can miss some things. So if you have a patient who usually makes ETS, the ETG method doesn't detect it. So you might miss some patients that way. The measuring range of the method, you want to go as high as you can, but keep it logical. So, we cut off ETG at 10,000 and ETS at 5,000 because that's compelling enough an argument, and we kind of move on. That was the coaching we got from Dr. Sperry and Marshalik when we built our method. So we just kind of went with that. We definitely know that time and dose for the ethanol consumption will influence what we detect. And we know that the clearance rate will influence what we detect. But the truth is, I can tell you either there's been a recent dose, if it's a low number, or that there was heavy drinking, maybe more remotely for a low result, but I can't tell you which one of those it is. if it's a low result. If it's a very high result, I can't tell you it was a very high dose within the last 24 hours or a chronic user over 10 days. I can't tell you those things, not the way we would really like it. So what we do say is this reflects a recent exposure, and that's about the best we can do. So we'll look at some things in a second here that'll kind of clarify that. So here's the fun thing about developing mass spec methods. Sometimes you can talk your own developers into a little experiment. And it came down to me as the bourbon drinker and one of our developers as a wine drinker. The wine drinker she's a technologist, so she's very fastidious and much better at collecting results than I am. So she did one 4-ounce glass of wine the night before work, came in and dutifully gave her urine results her urine specimens at 10 and 13 and 15 and 36 hours, as you can see from here, or pretty close to those. And what you notice is that after 1 unit of alcohol, the ethyl sulfate would have been positive. The ethyl glucuronide would have been negative by our cutoffs. Our cutoffs are 350 for EtG and 150 for ETS. So she would have had this sulfate positive, glucose negative profile, and it would have dropped off to nothing within another few hours. So that was something that made our eyebrows go up. And because we had a weekend coming, she said, hey, how about I increase the units of wine over the weekend and try this again? And we said, oh, sure, okay. So she did 3 4-ounce units of wine in a consumption. And you notice that now we have ethyl glucuronide in the bottom there going to 30,000. We can measure it. We don't report it that high. And ethyl sulfate at 20,000. So she had a really strong signal there. But again, we got out to 36 hours. We couldn't detect a thing. So it's a really sharp curve for a person who doesn't consume often. And we know that the behavior with addiction is not to just sip a little bit and stop. But what it does show is that time window is very sensitive, and it's kind of short. So, we're catching people more recently than later, I think. And in my bourbon experiment, I drank bourbon neat. I had ethyl glucuronide just at cutoff at 450 10 hours later, and no ethyl sulfate. So it was an interesting upside down profile where drinking clear liquor gave an ETG signal, but no ETS signal. So because we didn't reproduce it and we didn't swap and we didn't do a whole bunch of things, this is nothing we're going to publish. It's just kind of an interesting finding, but it was something that helped us with the dialogue on cutoffs and on time points in building the tests. So it's just a little food for thought. Also in the validation study, that was me. And so we can kind of, attribute this to the whoops moment that we did actually simulate that ETG pause, ETS negative without even trying. And so it was very simple to do and not fun. All right, so the sidebar, I wanted to take 1 minute and talk about another metabolite that is possible. And the reason I wanted to talk about it was because it's come up. And so I thought I'd use this forum to kind of clarify it. So next slide. Thank you. So there's one more pathway, and it's something that people have heard about. A couple of people have ordered tests for it, and I just want to put it in the presentation and make sure folks are aware. There is phosphatidyl ethanol, and this is when you take phospholipids like you have in your cell membranes or are readily available in lipid particles, etc., and you conjugate ethanol to it. And so this is good. Phosphatidyl ethanol was considered as an OB tracking device for ethanol consumption, but it never really took off. And the reason for that is we'd have to test every length of phospholipid acyl groups. So anywhere from C6 to C18, we'd have to do every single one of them in every single relationship. And it's just really a cumbersome method for measurement. ETG and ETS are much cleaner and much less complicated. So it is out there. There are tests that are available. I think one of the major reference laboratories offers this. However, next slide, there's a lookalike sound-alike test problem. Phosphatidyl ethanol, like I said, it is your alcohol consumption marker measured in urine, but there is a serum test called phosphatidyl ethanolamine antibodies, and this is for a vasculitis workup. So if you ever need a phosphatidyl ethanol test for any particular reason, please call and ask the lab for help in identifying the correct test. I won't try to say you have to do ETG, ETS if you feel like you need the other one, but please let me help you get the right one if you do need this one. So just just FYI. And now we'll get back to the EtGETS discussion. So we're at Ruby in December 2018, we quit screening. We stopped sending to the outside laboratory. We built our own test, and we did a mass spectrometry only approach to this. So we are in our first year of testing, and so far it's been really successful. Our approach is what we call 100% definitive, so you don't have to go through a screening step at all, and you just go straight to this mass spec. The ethyl glucuronide cutoff is 350, ETS cutoff 150, so if you add them up, they become 500. Very similar to the cutoffs that we use, but we take into account the ETS. And we can usually get the result out in about 3 days, and the range is 1 to 5 days from collection. So we try to make it pretty similar to what we had before and make it amenable to clinical work. But this was just kind of the outline of what we decided to do based on our experience from the year of sending it to another laboratory and dealing with the headaches associated with that. So when we get any result less than cutoff for either metabolite, we call that negative, which is why I said earlier, you know, if we have a number just below it, it ends up being neg, and that's just in our regulatory world what we have to do. If it's greater than or equal to the cutoff, we can call it a positive, and we can give that number to you. So, and that's pretty much every toxicology laboratory does it the same way. But we added an interpretation field to try to help out. Most of the time it works. About 98% of the time we can say it's consistent with, or, you know, probably there hasn't been consumption. Those few little percent that are in between are the one negative result and one positive result, and that gives you that supports but does not confirm recent consumption. That gives everybody a headache. We also add an adulteration check because we would like to make sure that we're just giving a spot check to see if there's been specimen dilution or maybe the addition of soap or an oxidant to try to change that result. And we put it all in the report for you so you can see it yourself and make some judgments based on that. So with that kind of background, I wanted to talk about how we built this test. Before we were sending, or before we captured that testing ourselves, we would get these interference results that said, you know, sorry, we have an interference. We can't tell you what's going on with the sample. And that wasn't very, very pleasing. So far in our laboratory, we have not found a contamination where we have said, yeah, I can call this interference. We have found some things that we thought were clearly negative because all of our criteria for positivity did not pass. Because we get to hold the data and look at it, and we get to say yes or no. So we call it straight. And so with the adulterations added to it, if you had a patient specimen that was old, that's been sitting on a shelf or maybe sat out on the counter for a while, or there were bacteria growing actively during the storage time, you would see shifts in the pH and specific gravity that might suggest it. So these are how we use these results. Overly dilute specimens, a creatinine less than 30, which is actually pretty low already, and specific gravity less than 1.01 starts looking like water. So you might start to assume that maybe tap water was added to the specimen. So these are some things you can think about if you look at the report and see those results. All right, but one thing we found when we were validating, and it's something that I wanted to be sure that the group here knows about, but no one else in the world can get their hands on. We test for interferences. We do a lot of it before we launch a test. And with ethyl glucuronide, we took a specimen that had 13,000 EtG units present and 6,000 ethyl sulfate units present. We added 1 drop of Dawn dish soap, and that detergent was capable of cleaving both metabolites and giving us absolutely zero returns back. We had a 2.5 in the EtG and an 18 in the ETS, which is, if I pulled a urine out of the urinalysis area and measured EtG, ETS, I would find similar results. So I took this to my annual meeting and presented it to some colleagues, and that they couldn't believe it, but they said, please do not put this in a journal. And I said, please believe me, I won't be doing that. But I did want to share it with you as providers, that if you've got a patient who's been trending down and it's looking pretty good, but all of a sudden goes to 0, it's kind of like, what did you do to the specimen? There's also that possibility. And we got no adulteration positive results on this. The specific gravity was fine, pH was fine, everything was fine. So we were not able to detect it.
So what's in dish soap that's not in hand soap?
That's a good question. There's something in Dawn, because it's the only one we tested. It was what was in the break room. So, you know, drop in there. but there's got to be a component in the detergent that is capable of cleaving those glucose and sulfate groups off so that we can detect it ahead of time. Yeah, I'm not really sure.
Unknown agent.
Yeah, so I guess we would have to sit down with our Dawn and our, whatever it is, the soft soap or whatever, and just see what the difference is. But it was an interesting finding. We put bench cleaner, which has bleach and detergent in it, and we still couldn't replicate it. So very interesting finding. Definitely a possibility. So don't let people in the kitchen with their urine cups would be my advice. But all right, so I had the cases. We have about 15 minutes. Okay, some of these are going to be super fast. Result set 1, we have EtG greater than 10,000, ethyl sulfate greater than 5,000, creatinine 120. We're expecting anywhere from 50 plus. Specific gravity 1.025, pH acidic, and no oxidants found. So would you be comfortable in calling this or not? Yeah, I would say so. Okay. So yeah. So recent consumption is confirmed, and we would say that the window is wide because we don't know if it was a recent high dose or what is going on. We just know that it happened. So that was way too easy. We'll go on to the next one. EtG neg, ETS neg, creatinine above 50, specific gravity physiological, pH acidic, and oxidants neg. Pretty clear negative, right? So it does not suggest recent consumption. It may be a little bit dilute, but it's not too bad. So this is not unusual for us. And that's results at 375 EtG, so above cutoff. I can give you a number. ETS 165, a little bit above cutoff. Creatinine 25 and specific gravity 1.005, which are both dilute. pH is neutral and oxidants negative.
Creatinine's dilute.
Yes.
What's not dilute?
Right.
It's probably much higher.
Yeah, you don't.
And I have a little discussion about that in a minute. Are there any questions? So no, that's you did exactly that. So dilute specimen, that would be my flag. I'd say, wait a minute. So probably light recent drinking, but recent abstinence could. But if I adjusted it for creatinine, which the magic formula is, that's a percent, right? So 25 milligrams per DL, if we're expecting 100, it's 25%. So you divide by your percent, you end up getting 1,566 or 660. So definitely you'd have a strong positive if you creatinine adjusted your results. So either way, it is positive, but one looks a lot better than the other one, doesn't it? Yeah, so that is allowable. All right, results at 4, we have an EtG around 400, a little bit above cutoff, ETS neg, creatinine low, SG low, pH neutral, oxidants neg.
Dilute, right?
Too diluted, not real urine.
Right. So this actually did come to me very recently, and I felt like it was really concerning. When I call it putting on my lab goggles, because when things are below cutoff, we put them in our information system to keep a documented record of the result, but we just can't show it in the chart because it's less than cutoff. And the result was 140-ish. So it was below cutoff, but definitely present. So that's suspicious. Oprah doesn't even like it. And here's that slide about creatinine adjustment. So I put it in the packet so that if you are attuned to any mathematics, you can kind of do a check on this. If you basically take your result and divide it by the percent, because you end up having this proportion to adjust, but 400 divided by 0.15, 15% gives you 2,600. And the 140 divided by 15% gives you 933. So it definitely shifts the profile and makes you think differently about how that result came about and what the circumstances were regarding the collection. Usually when I get this kind of question, my counter question is, does this patient have a urine concentrating issue? It's something that I can't see sometimes, and it may have never been worked up. Again, benefit of the doubt, I throw it out there. If the patient does not have a urine concentrating issue, then some tap water was added to this. So, all right, results at 5, we had EtG neg, ethyl sulfate 425, which is almost 3 times the cutoff. Creatinine 45, specific gravity 1.01, and pH acidic. But we have oxidants positive. So probably there is ETG present, but it might have been less than cutoff. This does happen in a scenario with the wine drinking. Having a low dose the night before in our healthy patient, our method developer, gave us pretty much this profile. So this specimen is a little bit dilute, but I would be concerned about that oxidant positive result. So I would also wonder about people trying to add things to the specimen to try to change that result. So Homer is very suspicious. All right, so those were the cases that I brought because I wanted to give a variety of different kind of profiles. Wanted to say that we are working to build more definitive testing here. So I want to learn more. What we have slated for this year is opioids, and it's taking us a long time because it's a lot of drugs. A lot of drugs in this panel that we're trying to pass all at the same time. So we're trying to cover heroin, the opiates, oxycodone and its metabolite, buprenorphine, Suboxone, separate naloxone detections, naltrexone, methadone, all of that stuff we're trying to do in a single go. So that if you give us a urine and you want it tested, you can get any of those drugs back, definitive, with low cutoffs. And then next is THC and gabapentin just by demand. It's just we're looking at how many are sent and what to hit first because of volume. But we do plan to cover the entire drug screening menu that we have at Ruby and to try to help whoever would like the testing with direct access to the definitive test without the need for a screen up front if you want to bypass it and look for compliance. So a lot ahead for us. And that was what I brought. Thank you. Sure.
That was wonderful. Guys, we do have about 5 minutes for questions.
Is it clinically practical to detect 6 mm in because heroin it's very short.
It's very
half-life, but I mean window times probably just a couple hours. So
it's less than a day in urine. It's pretty
definitely less than.
In serum, you burn through it quickly, right? You convert it and you're done. But it is detectable. We have found it. There have been some specimens that we identified that went through the Ruby laboratory where we had detectable 6 mm. So we were able to isolate it in the specimens. It's something that if you wanted to check for it, what we would like to eventually do is get the serum test going. So if you had an acute presentation, you could pull some serum and we could do the test and then you'd have a more definitive means. But yeah, it's a good question. And it's something that it's based on, I grouped them together. So I said, well, we can offer it. If nobody comes, we could turn the test off eventually, but we would have it available.
The question is, so we have this marijuana, we have like when we THC level, because we always try to see whether this patient's THC level is coming down. But for patients only, because I always wonder whether patient has been using, continuously, or they know when to use. So basically, or they probably have been using less and less, or just one-time use. My question is, I guess, one-time use. So does it make sense for us to track the level down and down, like in weeks time, in a couple of weeks time?
I actually had a case last week that came to me. The patient had been trending in the 3,800 nanogram to 4,000 nanogram area for THC. It had been going on for about 6 weeks.
So it's possible one-time use.
And no, not one-time use. This was a chronic user who said, I haven't used it all. I swear I haven't used. And so when I did literature review, I found that chronic users, it does take them a bit longer to come down, but they should be showing a steady decline instead of a plateau. So claiming that that a chronic user has quit and it's not coming down, there is no way to stuff enough THC into fat stores to justify fat loss or some of the other things that people reach for. You cannot keep it that high that long. It ends up finally coming down, and some of these patients who have been chronic users who are put in program, they say they haven't been using it. I'm like, I don't think that our slope is steep enough to say that that's the truth. One-time use, I don't know that many studies have been done on completely naive people with THC. I just don't. But I know that the detection window is anywhere from, I think it's 3 to 8 days on a single use. But I think that's even wider too, because it's lipophilic. It tries to get into cells and then it takes a while to get out of cells.
So in other words, if somebody in my weekly group reported one use one time, then 3 weeks after, the level is coming down, but still maybe the person is using less and less, right?
I would think they're sipping.
Okay.
Potentially. I think it would be really hard to tell unless they had a baseline that was low and then you saw a blip and you'd be like, hey, what are you doing? But yeah, when they have a high background, it's like having background noise on AM radio and then you're trying to get a blip to come out above that and you're trying to capture that. It's going to be really hard to do, especially considering that they know I have 5 days till my next visit potentially. So if I smoke now, then probably I've cleared enough out that I don't know how much math is really going into it, but I say there's a lot of potential for these things to happen, and we just don't know them. We don't understand completely all of the dynamics involved.
Another things like I heard before, because they did a study in like Europe. They put several people packed people in a telephone booth. And one person smokes marijuana and then checked everybody's urine, and everybody else actually urine was negative instead of positive. So by the way, if somebody stay with you, smoke a lot of pot, then doesn't mean your urine will be positive. It's almost like it's just a lie.
Yeah, there's the second hand. The second hand thing is like, well, I've got a roommate.
Right. So
I wanted to ask about alcohol testing and cirrhosis or liver failure. I know with medications, glucuronidation is spared in liver failure. Okay. And so I was wondering, what is the picture you're going to see with the more prominent ethyl glucuronide and less ethyl sulfate, or what happens with liver failure?
I think that's definitely a possibility. Your liver is going to try to retain whatever it can in terms of functionality, but as the parenchyma shrinks, you're just going to have a smaller and smaller capacity for it. So I would think you could see a shift in the profile. Absolutely, you could, to where you're getting more of one metabolite and less than the other. But sulfation is heavily used with drugs as well. So in a patient who's got cirrhosis, I guess it would depend on the stage and just how bad the situation has gotten.
Okay.
Mm-hmm.
Oh, another question is the degradation of ethyl sulfate and ethyl glucuronide linear over time, or is it some other curve?
The decline in a chronic user?
Yeah, so as they are abstinent and you're predicting the amount of time, just watching to see if it's getting out of their system, is it linear or what's the curve look like?
I would think it would be pretty rapid, because you saw what happened with just a single dose over a 36-hour period in a pretty healthy patient. So if you've got a chronic user, these compounds don't have anywhere to go. These are hydrophilic species, so they're not going to just compartmentalize and have a slower descent than you would have with THC. So I would think it would still be pretty linear. But I would really need to, that was one intention I had, was to pull our historic data, sort it by patient, and actually look at these dynamics over time to see if we could find any new information about it.
Thank you.
Mm-hmm.
All right, guys. If you guys have any follow-up questions, you're welcome to email me, and I'll forward those to Danielle. And thank you so much again for that.
Sure, no problem.
Our next session is on the 9th. I'll, of course, remind everybody about that. And Dr. Zhang is giving our didactic that day. But if you guys have any other questions, anything you want to hear about, just let us know. Thanks. Bye.
Okay, thanks very much.
Okay.